Yes, ma'am, we're ready.
Great. Good morning, everyone, and welcome to the webinar describing the recently released Minnesota APCD public use files. This webinar is presented by the Minnesota Department of Health Economics Program, which is responsible for overseeing the APCD. My name is Linda Green, and I'm Vice President at Friedman Healthcare. We provide facilitation and project assistance to the department on this project. Before we get started, I have a few housekeeping items for you. Would you please place your phones on mute for the duration of the presentation? We'll be pausing at several points throughout the webinar for questions. If you have a question, please submit it through the chat function on the control panel and send your questions to presenter. We will also try to answer your questions during the webinar. However, if we're unable to get to that particular question, we'll post a written list of Q&As, questions and answers, alongside the recorded webinar after we conclude. So the purpose of today's call is to introduce an exciting new initiative from the Department of Health Economics Program to provide public use files derived from the Minnesota All-Payer Claims Database to the public. We'll start by giving you a brief history and background of the public use files, or PUFs as we call them, and then we'll dive into the details of what the current set of PUFs look like. We'll also walk you through the process for accessing the public use files and show you where to find detailed file descriptions and other resources. Finally, we'll take questions from the audience. So let's first talk about the history and context for the public use files. The foundation for the PUFs is the Minnesota All-Payer Claims Database, or the APCD, a large-scale database containing health care claims data from public and private payers in Minnesota, as well as from Medicare data files. The state legislature authorized this initiative in 2008 as a way to bring transparency to the healthcare market. This database is administered by the Department of Health. Overall, the Minnesota APCD contains claims data for 2009 through 2015. Using this information, the Department of Health has generated the first set of PUFs, and we'll talk a little more about that process in a bit, using data from calendar year 2013. Within the APCD, the 2013 data represents 4.2 million Minnesotans, including those covered through public and private insurance, and a total of 175 million medical claims and 65 million prescription drug claims. In general, the APCD provides information on the diagnoses identified when those individuals sought care, the specific procedures or health care services they received, and how long their treatment lasted. Note that demographic information is de-identified with respect to age, gender, and geography of residence. Health plan product information is available at a high level. We'll talk more about that in a little while. The database collects and manages these data from 62 submitters representing the public, commercial, and self-insured markets, and includes information on payers, providers, and payments for healthcare services. As the administrator for the Minnesota APCD, the Department of Health uses the APCD to analyze variation in healthcare cost, quality, utilization, and disease burden. The state legislature has also authorized MDH to use the database for certain evaluation activities, including evaluating the performance of the Healthcare Homes program, studying hospital readmission rates and trends, and studying trends in spending for specific chronic conditions and risk factors. The database is fully de-identified, which means that before any data are submitted to the APCD, direct patient identifiers such as name and date of birth are encrypted. This is a standardized, one-way process that prevents anyone from reversing the encryption and identifying specific individuals. Finally, it's important to note that the Minnesota APCD contains information on Minnesota's insured populations only. It does not contain data on the uninsured. The database also excludes populations covered through certain government programs, specifically TRICARE, the Indian Health Service, and the Veterans Affairs Department. So I wanted to give you some background on the history of the PUF development process. Recognizing the value and potential of the Minnesota APCD, the legislature established an advisory group in 2014 to inform future directions for the APCD. This group met periodically during 2014 to discuss ways to expand use of the database. Within the advisory group, there was strong support for making certain information from the APCD available to the public. One of the advisory group's recommendations to the legislature was to create a widely accessible file called a public use file. In response to these recommendations, during its 2015 session, the legislature directed the Department of Health to develop PUFs from the APCD. The legislature emphasized an iterative process for developing the PUFs through ongoing user engagement and feedback. In particular, the iterative process involved bringing the advisory group back together to discuss principles and guardrails for the PUFs, as well as rolling out the PUFs over the course of 3 years, beginning in 2016 with an initial set of PUFs and then continuing to refine and expand the PUFs through June 2019, importantly based on user feedback. In particular, the legislature established the following principles for the PUFs. They must be available to the public at no or minimal cost, available for download by June 2019, that data about patients, providers, and payers continue to need protection, that the files should be updated at least annually, documentation should clearly explain the characteristics of the data, and finally, that the sole source for the PUFs should be the Minnesota APCD. So using input from the advisory group and in keeping with the legislature's guardrails, the Department of Health has prepared the first set of public use files. All PUFs contain summarized, aggregated claims data from the Minnesota APCD and provide information on insured Minnesota residents who received healthcare services. These files are considered public data and, as such, are available to the public at no cost. The files are intended to provide helpful, usable information in a manageable file size while protecting privacy of individuals, payers, and providers. The PUFs focus on 3 main themes: services, diagnoses, and use. The first topic, healthcare services, refers to the volume of healthcare services among Minnesotans. Second topic, primary diagnoses, refers to the distribution of primary diagnoses for Minnesotans when they received these healthcare services. And thirdly, the healthcare use topic refers to the different types of healthcare services used by Minnesotans, for example, emergency department visits or a primary care clinic visit. The PUFs are based on the full APCD and are therefore very similar to the source data. The PUFs use the same protections that are put in place to protect the identity of individuals. And because the PUFs are derived from the APCD, they were subjected to the same rigorous quality assurance processes as the full data set. Also, because the PUFs contain summarized aggregated data from the APCD, there are certain elements included in the full data set that are not retained in the public use files. In particular, the PUFs do not provide identifiable information on providers or payers in line with the legislative guardrails that establish the PUFs. In addition, the Minnesota APCD contains data on some smaller segments of the population, such as small zip code areas that are grouped together in the PUFs to prevent re-identification. And because the information in the PUFs is aggregated, the files do not provide the same level of analytic drill down as might be available in a larger, more detailed data set. So the PUFs can describe a number of, illuminate a number of topics about healthcare. They can shed light on disease prevalence, disease prevention, chronic conditions, service utilization, access to care, and cost trends across the system. The PUFs support the state's commitment to open data and a willingness to provide users with reliable data to achieve the triple aim of improved health, better care, and lower costs. Providing researchers with access to data from the APCD expands the potential impact and fosters an environment of mutual learning and data quality improvement among state and public data users. So at this point, I'd like to pause for any questions. Please note, send the questions via the chat function and address them to questions for presenter, please. I'll just pause now.
Good morning, everyone. This is Stefan Gildermeister. I direct the Health Economics Program, and I'm here with a team from MDH who is helping to convene the webinar and answer the question. We have a few questions here from folks in the room, and some of the questions may have already been answered, but I'll go through the list. There's a question about the duration of treatment per provider and per condition, whether the APCD manages or retains that data and how it's sort of recorded in the data. I think I want to make the following distinction. The data in the APCD is recorded by service dates. So to the extent that a duration of treatment spans over several service dates, it would be captured. The PUF data, as Linda mentioned in her remarks, are much more rolled up. So unfortunately, at this point, episodes are not a focus of the PUFs and can't really be identified through analyses because the data is rolled up at the geography and age group level. We may discuss this in the next, but the aim, of course, of the PUF strategy is to look for ways to make the data more broadly useful and structuring data still subject to guardrails in a way that sort of gives us a sense of encounters is sort of one of the options that we will be thinking through in the next 12 months or so. Second question was, are data related to workers' compensation part of the Minnesota APCD? And at this point, they are not included. As part of MDH's strategy to establish and maintain a robust data systems, we are looking for ways to integrate data from payers who are not currently part of the data. Overtime and workers' compensation and the Veterans Administration are sort of one of the primary targets, so to speak, but at this point they're not included. A question about when data has been aggregated or redacted. Is it possible to see that so that you have a sense of the volume and the cost of data that's been redacted? And the answer to that is yes. The documentation contains that information. But anyone who, when starting to work with the data, has follow-up questions may, of course, reach out to staff at MDH, and I think we've provided in these slides and on the website links to the help desk for the APCD. Question about the guardrails. And this refers to the criteria and the conditions under which we are permitted to publish public use files today and into the future. The legislature made a number of distinctions as part of the publication of the public use files. So there are different guardrails for working with the data on research projects that MDH and its contractors are working on. But for the purposes of the public use files, the threshold or the guardrails are a bit more tighter. So generally, of course, our responsibility is to shield the identity of individuals in any work that we're conducting. That is, of course, to some extent already accomplished by hashing individually identifiable information. So what the data does not contain is identifiable data. It's redacted and hashed into a use ID before the data comes to MDH. So at some point, to some extent, the data is already by being de-identified, it's already protecting the identity of individual patients. What the public use files do in addition to that is eliminate information on service dates, of course, but also by rolling up individual patients into age groups. That's another element in protecting individual identities. The other two criteria that we were directed to consider were to protect the identity of providers, hospitals, clinics, and physicians, and of health plans. So what that means is that in no cell across geography and age, the goal of the redaction is to make sure that no cell permits direct or indirect identification of providers and health plan companies. And with sort of some concentration in providers and health insurance coverage across the state, that's a pretty high threshold, which resulted then, as we discuss, in the kind of redaction strategy that we've used for this first set of files. We're of course interested in conversations with potential data users of how to manage the balance between maintaining the guardrails but providing a granular enough data to make analysis, to make it meaningful for analysis over the next couple of months and into the next year. The question about when will the files be sent. I think the process that we employ is that users reach out and request the data files, and then we process that request internally and submit them within a few business days or a week or two. So for those who've submitted data files, you should receive them within a 2-week window. If you haven't, please touch base with us again. There's one data file that contains CPT codes, and we're still discussing with the AMA how we may be permitted to even publish those rates, even though definitions for individual CPTs are not included. So that it's a matter of intellectual property that the AMA holds. So another question about granularity of the data. You know, how can one look at access to care? Can we see to what extent providers have been accessed in a certain order? These data files do not permit that whatsoever. The data files really are at a very aggregated level. So imagine that you would have, for a certain 3-digit zip code, and for a given diagnosis code, entries for each age group. So there is no information on providers here, of course, because that's not permitted by state law, and no service dates included. I want to reiterate that point again. The data is highly aggregated as required by statute. We know from discussions with researchers who we interviewed in the process of developing these data files that many will not be happy about that level of aggregation. But it's sort of the place where we are considering concern about what the implication of using or making available more granular data. We have a question about the extent to which data are linked to other data sets. For instance, the American Hospital Association and provider characteristics, permitting perhaps a study of mortality. I will go back to my main point in saying the data is very highly aggregated, so there is no hospital-level information in the data, because that would mean identifying a hospital, which is not permitted under the statute under which these data files are provided. The same about provider characteristics or individual mortality data. The only linkage that we can imagine possible at this point, and the data files are public, so to the extent that users wish to integrate data probabilistically or otherwise, would be data on the underlying geography, or perhaps data on characteristics of individuals within age groups. But again, that is up to data users to experiment with. We have one more question, and then I would suggest we go back to the presentation. The question is about the extent to which the data files may be used to describe health system cost trends. How do the PUFs enable this from occurring? So there are essentially two dimensions in each data file. There is a count of events, whether these are number of diagnosed conditions or diagnoses made, or number of procedures performed, and the cost for this volume of procedures. And then, of course, it can be calculated as an average cost per procedure. Over time, and this is currently not possible because the data that is submitted in this first round of public use files is limited to 1 calendar year. But as I mentioned, the evolution of the suite of public use files designed from the Minnesota APCD involves making data available over time, and of course also scaling it up to different topics. So the trending of cost will be possible at the point at which we make multiple years of data available. As Linda mentioned, we are required to at least annually update the data files. I think we will, I'm certain we will aim to update some of these files more frequently, and I think the logical first step might be to replicate a single year of data with multiple years, and that's what we will likely aim for as resources are available to implement this work. So with this, thank you for the very good questions, and I'm passing this back to Linda Green.
Thank you, Stefan. So, as you've heard, there are 3 separate puffs. I thought in this next section, we'll describe some aspects common to all 3, and then move into a description of each file's particular structure and characteristics. This will touch on some of the questions that you've already shared with Stefan. So, the 3 files share several common characteristics and features. All the files contain medical claims data from calendar year 2013, and pharmacy claims are not included. In each of the files, the subgroups are zip codes and member age. In general, there will be 16 3-digit zip code categories, and there will be 3 age group categories: children and youth less than 18, adults 18 to 64, and older adults age 65 plus. In general, this results in 48 rows for each condition or service. In some cases, the total number of rows may be less than 48 due to redaction rules for small numbers in non-residential zip codes in Minnesota. You'll see how this plays out as we go through the slides. A second important feature is that the files have been designed with particular attention to protecting against re-identification, as Stefan mentioned. When necessary, small cells are presented at a higher level of aggregation. That is, records with fewer than 11 patients are redacted and rolled up into a larger group. This aggregation is in place to be consistent with the legislative guardrails to protect identification of individual patients, providers, and payers. This particular level of aggregation was chosen to, as we mentioned, to prevent the re-identification of individuals in a particular geographic area or age group with perhaps a rare condition. The aggregation also prevents re-identification of individuals that might occur if the PUF is linked to an external data set. Redaction occurs first at geography level and then, if necessary, at the age group level. Also note that the PUFs do not include the records associated with fewer than 20 healthcare providers or fewer than 4 distinct payers in a particular area or category. Since each file contains different views of the same information, the specific redactions will differ from file to file. The hierarchy was to protect patient identity and then to redact based on payers and numbers of payers and providers. After 2 rounds of redaction, the information, the underlying records are not included in the published PUF. All files are available in Excel and CSV format. The largest file, unzipped, is 4 megs, just to give you an idea of size. In terms of the PUF derivation process, there were 4 steps for each of the 3 files. All of the data is based upon transactional records that have been processed, reviewed in these steps. First, the individual transactions are consolidated into one record by combining multiple versions of a single claim. These multiple versions occur in the standard course of a provider and payer relationship and need to be organized in a logical manner. Second, all the duplicate records from multiple sources are organized into a single record. Third, the individual records are grouped and summarized by service or category, zip code, and age group. Fourth, small cells are redacted, first at the zip code level and then by age group, with the goal of retaining as much data as possible in the PUF while providing necessary identity protections, as we mentioned, to patients, providers, and payers. So here's an example of how this 4-step process worked as applied to one of the three files, the primary diagnosis file. In 2013, payers initially submitted about 212 million claims transactions to the APCD. After consolidation, that's the first block there, and deduplication, the second level, about 177 million unique records remained. Records with key missing data elements were also removed at this point. After aggregation and redaction processes were concluded, about 175 million claims records remained, about 99.7% of the total submitted, and about 99.5% of the total dollars. In future versions, MDH will look at combining small cells into larger groupings to retain the information in the file. MDH will continue to sharpen and evolve these files over time. We'll also point to the derivation and summary statistics documents that are available on the MDH website. I'll pause here for any questions about the redaction process.
We have a question about whether the slides will be available, and yes, they will be made available online, and if it's too difficult to find this online, feel free to send us an email at, Jen, can you help?
health.apcd@state.mn.us.
Okay, that was health.apcd@state.mn.us, and we'll make those that link later on in the presentation.
Thanks.
There are no more questions at this point.
Okay. So now we'll start talking about each of the three different PUF files. The first is the primary diagnosis PUF. It shows the distribution, frequency, and cost of certain conditions diagnosed during a healthcare visit. The diagnostic information comes from the primary diagnosis information recorded on the medical claim and uses ICD-9 diagnosis codes summarized at the 3-digit level. It shows the distinct member count and total paid amount associated with each diagnosis code. The raw data going into the PUF had 175 million records, representing about $26 billion in spending. The published PUF, after the redaction process, contains data based on 175 million records and $26 billion of spending, about 99.7% of the original records and 99.5% of the dollars. The file itself has about 26,600 rows with 961 unique diagnosis codes. And please note, since this is a 2013 file, based on ICD-9. The primary diagnosis PUF could be used to help answer questions such as, what is the frequency of a particular diagnosis reported by providers on medical claims? What is the distribution, how does the distribution of patients with certain conditions vary by age and geographic area of residence? How much was spent on care for insured patients on average for a visit or procedure under a specific primary diagnosis? How many patients received a particular diagnosis? And among all patients that received this diagnosis, what was the average total amount paid? So here's an example of how this data could be explored. In 2013, there were 13,085 diagnoses of strep, sore throat, and scarlet fever, ICD-9, CM034, among children and youth under the age of 18 in Minneapolis, which is 3-digit zip code 554. Combined spending for patient care related to this diagnosis was about $2.6 million. For the primary diagnosis file, This table, let me start again. This table illustrates the variation in the effective redaction rules for the primary diagnosis file for particular geographic variation. So, although the data are very complete overall, data richness in some of the specific lines will vary. For example, in this table, in the 3-digit zip code area for Minneapolis, which is densely populated and has a high concentration of payers and providers, all the data moved forward into the PUF. No redaction was required. In comparison, in the Northeast, which is 3-digit zip code 556, 80% of the records for those under age 18 moved forward, while 91% of the records moved forward into the PUF itself. Users should compare the PUF data to the summary statistics available online to determine whether the data are rich enough for the specific purpose or particular question that's being explored. The summary statistics, as we noted, will be available on the web page. Second PUF is the healthcare utilization file that shows the distribution of utilization and total amounts paid across different types of healthcare service use categories. These categories include office and clinic visits, nursing facilities, hospital admission, and ambulance services, among others. Users should consult the data dictionary available online for a full list of categories. This version of the file does not separate out ED visits, but MDH anticipates adding that in a future version. The raw PUF contained information on from 176 million records and $26 billion. After redaction processes, nearly all the dollars and records were included in the file. As you can see, 99.98% in both cases. The PUF itself has 531 rows and has 12 service categories, as I mentioned above, starting with office and clinic visits, nursing facilities, etc. So this PUF could be used to answer questions about the type of settings in which care was delivered. It could be, for example, in what type of setting did patients receive care? What are the patient characteristics, that is, age and geographic area of residence where this care was in the setting? How much total health care spending was there for health care in a particular setting? Number of patients, the average total amount paid for care provided in a particular setting. So here's another example of the kind of question that might be explored with this data. In 2013, there were about 1.4 million encounters in a clinic or office setting among children and youth under the age of 18 in 3-digit zip code in Minneapolis 554, and the combined spending for care related to these visits was about 181 million. This slide shows you a little bit about the variation in redaction. While the data is very complete, again, we do want to note that the redaction varies based on geography and age. For example, redaction rules had very little impact on the Minneapolis data and adult age categories in the Northeast 3-digit zip code area, 556. However, 99.8% of the total dollars are represented in the overall published PUF. Again, please consult the summary statistics when using this data. The third public use file is a healthcare services PUF that shows the volume and distribution of the healthcare services used. Data are provided at the service code level, that is, procedure codes and revenue codes. The file shows counts of individuals and services and total dollars. The table on the right-hand side shows the effects of the aggregation and redaction processes. The final version of this file represents about 93.4% of the original records and 86.4% of the dollars. This PUF is the largest of the three files and contains about 70,000 rows of data. Information includes 3-digit zip, age group and age band, service code, code class, that is CPT or HCPC, and total dollars. Examples of the types of questions a user might consult this file to answer include, in the aggregate, what procedures were delivered in a calendar year to patients in certain age and geographic combinations? How did this vary across the state? Another question is, what's the age, gender, and geographic area of residence of patients using different types of services? Or how much on average and in total was spent by payers and patients for a particular service? How many times was a particular procedure performed over the course of a year? And here's an example of a type of question you might answer. In 2013, there were 121,332 claims for 25-minute outpatient office visits, CPT 99214, for 65,000 children and youth under the age of 18 in Minneapolis, zip code 3-digit zip 554. The combined spending for outpatient care related to these visits is around $14.6 million. This slide shows you the effects and variation in redaction for this particular data set. This is driven largely by differences in geographic density when looking at the procedure or service code level. So you can see where, again, in Minneapolis, 3-digit zip 554, more people, more providers, a high degree of raw data remaining in the published PUF, more variation in the Northeast area where there are fewer records that could move forward for children under the age of 18. But overall, the percentage of claims records remaining in the PUF after redaction is quite high, 93.4%. I'm going to pause here for questions and turn to my colleagues at AGP.
Yeah, hi, this is Stefan Gildermeister again. It seems the last couple of slides really got the creative juices flowing here. We've got a number of good questions, so I'll take them one at a time. Question about multiple payers and to what extent they can be identified in the data. So at this point, payer type has not been disaggregated. Data across primary and secondary payers have been rolled up in terms of their cost, but they're not separately identified. And I think the reason for that, again, is that when we create that additional level of stratification to the data, it makes every cell that we currently have smaller, resulting in greater disaggregation, greater need to redact a greater number of cells. Now, in the future, one might imagine producing some summary statistics at different levels of aggregation, maybe removing age categories from it, but we hope to hear from the user community about whether that's a useful next step and how to best design that with guardrails in mind. Second question, can the files be merged to dig in deeper and better understand, for instance, how distribution of sites of care differ across different types of condition? And I think the answer is yes, the merging can occur, but no, it will not produce the greater insight that you're looking for, because the only link between the files is geography. So essentially, it does not. There is no link between the condition across the files, at least not at this point. So again, as a researcher myself, I realized the limitations of this level of aggregation, but at this point, that's just not been possible with the guardrails under which we're operating. So, question about whether we will make additional years available, and the answer to that is yes. We're finalizing 2014 data. Integration in the APCD, so moving forward is certainly part of the plan, but moving backward is also a possibility, and we will consider that as part of the strategy moving forward. A question about whether the data permits identifying differences in use across provider specialties. At this point, no. But that's a really legitimate research question, and we can certainly imagine designing files that focus on specialty, although probably it would require different kind of stratification, perhaps removing geography to remove the potential for identifying individual providers, clinics, or hospitals. There's a question about whether gender is part of the data and race ethnicity is as well available, and also follow up again on type of payer. The underlying APCD, the underlying data contains sex and fairly granular payer information, including some specific payer groups, payer codes that permit distinguishing between Medicaid and Minnesota Care. The summary files, the public use files, do not retain that granularity. Again, for the purposes of finding that balance between making available rich information with little redaction and sort of operating within the guardrails under which we're required to operate. Race and ethnicity is not typically part of a claims data file, and is also not collected. It's not part of the Minnesota APCD. It is an incredibly important demographic factor, just not one that's available with this data set. The question about the payer types I want to elaborate on a little further. So there certainly is the possibility of taking very rich and health plan specific payer statistics and rolling them up either into Medicaid, Medicare, and private, or even just distinguishing private and public. And that's definitely something that we're considering for future public use file releases, and would love to hear more from again, the user community about what kind of stratification would be particularly useful with that. Will we make available a map of 3-digit zip code areas? I think there is a map, or at least a crosswalk in the documentation, but I think a quick Google search will produce that as well. There are 16 3-digit zip codes in Minnesota. So they are fairly evenly distributed across the state. I should say we haven't picked them because we think that there is some magic healthcare pattern embedded in them. We realize the zip codes serve primarily the function of figuring out how to get mail to, how to organize delivery of mail to households. But in weighing different geographic factors, the 3-digit zip codes for this first set of files seem to be a decent compromise in again, finding that balance between granularity and living within the guardrails. Question about whether the data can be requested for a specific procedure or a given diagnosis. I'll answer this by saying the data is designed in a way that analysts can filter the data to identify specific procedures and given diagnosis. I think our resources to provide to query this public use files for users is limited, so I would encourage analysts to take a crack at this themselves. The data files, because they're so aggregated, are fairly straightforward, and identifying counts and total dollars spent on procedures and diagnoses will turn out to be pretty straightforward. There's a question about how one might cross-reference the 3-digit zip codes to other geographies that are more commonly used. It's definitely a challenge because the zip codes don't comport well with other geographies, not with counties, and not with other geographies because they don't align well with county boundaries. There are crosswalks between 5-digit zip codes and county borders. What I will say is we might take this question back to our analysts and see if there is additional, if there are some crosswalks we can provide that is somewhat helpful, sort of telling people which counties are fully or partially embedded in a zip code. So hopefully we can help with that. I think the alternative to that is, of course, designing these files in the future at different levels of geographies, and we're open to hearing which type of geographies are would be meaningful to users. And with that, I think we have one more question, and then I will turn this back to Linda for the remainder of the presentation. So a very specific question around what is included in the total cost data for this analysis, and I think it's similar to a question that was asked earlier, which I could have answered more fully. I'll do it here in a second attempt. The cost per procedure, or across all procedures, or the cost across a single diagnosis, covers both the allowed amount and the patient cost sharing share. So it is it's a sum of all primary payers and the patient's responsibility. So with this, again, thank you for the second round of good questions, and back to Linda.
Thank you, Stefan. So in this last segment of the presentation, we're going to talk about how to access the data and point you to some helpful resources. MDH has designed a simple, straightforward process for users to request and receive the PUF. The intent is to make access as easy as possible while also putting the department in touch with potential users to start building a PUF user community. I think you've heard that from some of Stefan's answers, that we do want user feedback. There's a public use files page that includes a downloadable data request form. This is a simple one-page form that asks the user to provide contact information and indicate which PUFs they'd like to obtain. There's also a brief data disclaimer that users are asked to complete. Users can then mail the completed request form to the department's APCD team, who will reach out back to the user to coordinate sending the files. As I previously mentioned, the primary purpose of this data request process is to build a user community. Releasing public use files from the APCD is a brand new initiative, and Minnesota is a leader in this among other APCD states. So it's important for the department to communicate with PUF users throughout this process to provide technical assistance at some degree and share findings and lessons learned. We also are very interested in user feedback on their experiences with the PUF. This is just the first round, and in the future the department would like to enhance and expand the PUFs to better meet users' needs. Because of this iterative and interactive process, the department will reach out to users to gather their feedback through surveys, and use that feedback again going forward. So some resources that might be helpful to users. First, please consult a series of documents on the Minnesota APCD website which describe the current set of PUFs. First, there's a PUF overview document which gives a general summary of the initiative and describes the PUFs in clear layman's terms. Second, the department has provided a more detailed technical document for each of the 3 PUFs, including a data dictionary that describes each data element in the file. Third, users should consult the summary statistics table that shows summary totals for each file that in its format before the redaction process. Users can compare these totals to those in the final published PUF to understand the level of data that was redacted. Finally, each PUF also has a derivation document which walks users through the process for developing the PUFs from the APCD data set, including each stage. All of these resources are available for users on the website. We'll continue to update the PUF webpage, so please check the site for future updates. Also, please reach out to the APCD team with any questions about the PUF. There will also be a mailing list that you can join if you're interested. The email address is shown at the bottom of this slide. So as you've heard, looking ahead, the department expects to update the current set of files at least annually as more recent data become available. The department is also in the process of exploring options for new or expanded PUFs that include more years of data. We look forward to gathering feedback through the survey and throughout this process to inform future PUFs. Finally, there will be a frequently asked questions document that will be created and posted to the website with updates as more questions are received. So we are near the end of the hour, but I will take more questions. Or my colleagues at AGP will take more questions at this point.
Yeah, looking at the chat list at this point, there are no additional questions. So I'm going to fill the time maybe by making a few closing comments, but we're happy to take more questions as they come in. We've said a lot about the guardrails and the limitations that they present for analysis and use of the data and better understanding the healthcare delivery system. At the same time, I think what I want to acknowledge is that this is a first foray into making very new and granular and reasonably granular data available to analysts, and we expect and hope to learn over the next couple of months and years what additional data is helpful and at which stratification that is helpful. We will share with the legislature what we have been learning from use of the data and how the data has been helpful to analysts and how additional cuts of data may perhaps increase our knowledge about the healthcare system and about opportunities for producing good health at affordable costs into the future. As a team here at MDH, we're excited about this step occurring. Nationally, there are a number of states with APCDs who have sort of explored establishing or making available public use files. I think Minnesota is if not the first, then one of the first to make these files available. Other states have more direct research mechanisms in place where external users can query the data directly for approved projects. That's not the case in Minnesota, but nevertheless, I think there are a fair number of opportunities to learn about the data, to learn about the quality of the data for an initiative that is, quite frankly, not that old. We've been collecting the data since 2009, but have been able to use it sort of for a set of research applications since 2014. So our shared exposure to the data is relatively new. So we're looking forward to some of you taking advantage of the data with a different set of expertise than we bring to it, clinicians, advocates, and others, to make use of the data and challenge us to make the data available in formats and in stratifications that make most sense. I would say our team is small, but is looking forward to hearing from you and working with you. If you have questions about the data, about how to interpret it, feel free to reach out. When we cannot help, we'll make sure to communicate that. Again, the email address that you want to note down to reach out to the team is health.apcd@state.mn.us. You may also use this email address to request a copy of the presentation slides. Otherwise, the presentation slides can be accessed through MDH's website, health.state.mn.us, and by searching for either APCD or public use files or PUFs. So with that, I think there was another question. Jen, can you scroll up?
Yes, sorry.
Was actually two questions. What's the expected timeline for turning around the data files? As I mentioned, it should be about 2 weeks, and it should move much quicker into the future. I want to remind you of the disclaimer that we had, that we're still trying to figure out mechanisms by which we can actually report CPT codes as part of the service file. There is a question about whether we will consider making more granular data available to qualified researchers through data use agreements for IRB-approved projects, etc. At this point, the legislature has not imagined a space for that, so we cannot make that data available in formats that permits identification of health plans providers or potentially individuals. It's just not where Minnesota is at this point. So with this, maybe one last call for questions. Are there any more questions on the data files, the presentation today, what we've said in answer to your questions? If not, then thank you everyone for your interest in these public use files. In advance, I think I want to thank you for being engaged in designing a growing and evolving suite of public use files. We look forward to hearing from you, to working with many of you in the hope that these data become even more useful than what these 3 files may present at this point. So thank you to everyone. Thank you to Linda and her team who facilitated the conversation, to MDH team in the room, and to everyone on the phone.
Thank you all very much. Have a great day.